Now, clinical case related to the Mobitz type 2. A 78-year-old man is brought to the ER because of the fatigue and lightheadedness. He does not have chest pain, palpitation, or difficulty breathing. He has history of hyperlipidemia, type 2 diabetes, mellitus, hypertension, osteoarthritis, asthma. Current medications include simvastatin, metformin, lisinopril, albuterol, ibuprofen. His pulse is 48 per minute and blood pressure is 89 by 50. He responds slowly to the questions but is oriented to person, place, and time. Examination shows dry mucous membrane. His lungs are clear to auscultation and vowel sounds are positive with no pulsatile masses or broods. Pedal pulses are non-palpable and dyslextemies are cold. Capillary fill time is 4 seconds. An ECG shows left axis deviation and Q wave in the lead 3, a constant PR interval of 0.15 second with every third P wave that is non-conducting and curious complex interval of 0.09 second. Which of the following is most appropriate next step in the management? First, we do the diagnosis, then we will see what will be the management in this case. Patient presents to us patient presents to us with fatigue and lightheadedness. Then patient not respond to questions. Patient is mildly confused. Then there is the bradycardia, 48 per minute. Then hypertension. So patient presented to us with symptoms, and we say the hemodynamically unstable patient. And there is also the dry mucous membrane and increased capillary fill time and non-palpable extremities showing the hypotension and hypoperfusion. And ECG, in the ECG there is the left axis deviation and Q wave in the lead 3. uh, Q wave are finding in the single lead are mostly non-significant. The constant PR interval of 0.15 second, which is the normal uh, interval, as the normal PR interval is between the uh, 3 to 5 small boxes, and this is less than 200 milliseconds or zero point 0.2. Then it also mentioned that QRSM complex is interval of 0.09 seconds, which is also normal because the normal QRS complex is 2 to 3 small boxes, which is 0.8 to 0.12, which and it lie in the normal. Then he said to us that every third P wave that is non-conducting. It means that there is the P wave, there is the QRS complexes, then there is again P wave, then there is the QRS complexes, then the third P wave, and there is the pause, then P wave and this one. This P second and third P. He said to us that the PR interval is constant. All the PR intervals, he said to us, but I cannot make like that. All the PR intervals are constant and every third beat is non-conducting. It means that patient, our diagnosis is Mobitz type 2 block, and also patient is symptomatic and heart rate is 48. So what we will do we either we do the dopamine, we cannot give the dopamine, we cannot give the glucagon. Dopamine increase the heart rate and we will not do also do that. Norepinephrine will not be nothing to do with that. Epinephrine will not do that. We do the cardiac pacing, temporarily transcutaneous cardiac pacing, and then permanent pacemaker will be applied to this patient. Here our topic of today ends.